Hey, welcome back. Today we're talking about something that might make you a little uncomfortable, and that's exactly why we need to talk about it. As many of you already know, I'm also a firefighter, and I have zero formal training as a psychologist. Zero. But when I respond to a call and someone's in crisis, maybe thinking about self harm, overwhelmed, or scared, I can't just say, I'm not qualified, call a psychologist, and walk away. I have to be present. I have to listen. I have to help. And here's what I realized. As a massage therapist, we're in the exact same position. You've probably been told your whole career, stay in your lane, don't overstep, refer to a psychologist. And I get it. That makes sense. You're not a therapist, at least a mental health therapist. And you don't want to get in trouble with your regulatory body. And you don't want to make things worse. But what if I told you that by not having that conversation, you might actually be missing one of the biggest opportunities to help your patients? Today, we're going to break down what a crisis actually is, how to recognize it, and what you can do about it without being a psychologist. Because the research is clear. You are uniquely positioned to help, not as a therapist, but as an ally. Let's dive in. Hey there, I'm Jamie Johnston, and you're stepping into a new era of thriving as a massage therapist. We're embracing who you are, pursuing what you love, and confidently shaping your practice. We'll challenge industry norms, spark change, and discuss what truly matters. Things like mental health, evidence-based practice, and some topics we've long avoided. Let's create better outcomes for our patients and happier, more fulfilling practices together. Welcome to the New Generation Massage Therapist Podcast. So first, let me paint a picture of what's actually happening out there. There's a massive shortage of mental health professionals. We're talking like months-long waiting lists. People can't get appointments. And when cost, geography, or disability gets in the way, well, forget about it. Now, here's where it gets relevant to you. When your patient comes to you with mental health struggles, things like anxiety, depression, or maybe fear about their injury, they're often resistant to being referred out. You know why? Because they think you're dismissing their pain as it's all in their head. So what happens? They don't get help. They stay stuck. Their recovery stalls. And you're left feeling like you can't do anything because you're not qualified. But here's the thing. The research shows that manual therapists like us are uniquely positioned to bypass these barriers and reach patients who would otherwise fall through the cracks. You're not replacing a psychologist. You're filling a gap that desperately needs to be filled. And that brings us to the first thing that we need to understand. What is a crisis actually? A lot of people throw the word crisis around, but let me be specific about what we're actually talking about. A crisis is defined in the research as an overwhelming event, like a serious injury, a divorce, losing a loved one, or getting a scary diagnosis that threatens someone's well-being or sense of safety. And here's the key. It's not just having a bad day. A crisis is when someone's usual coping strategies aren't cutting it anymore. They're overwhelmed. They can't think straight. Their normal way of handling stress just doesn't work. Now, you might be thinking, okay, but how does this show up in my treatment room? That's where we need to talk about something called cognitive appraisal. This is how people evaluate whether something is a threat and whether they can handle it. And the research shows this happens in two stages. The first stage is called primary appraisal. The person thinks, is this dangerous, or is this a threat to me? And the second stage is called secondary appraisal, where the person thinks, can I cope with this? Do I have the resources to handle it? And here's what's wild. These appraisals matter more than the actual event itself in determining how someone responds. So two people can have the exact same injury, and one person thinks, okay, this sucks, but I can handle it. And the other person thinks, I'm broken. I'll never recover. My life is over. Same injury, completely different crisis response. And that's where you come in, because you can help shift that appraisal. So how do we actually recognize when someone is in distress, when their appraisal has shifted into crisis mode? Well, the research shows that distress manifests as feelings of overwhelm, worry, anxiety, fear, helplessness, and even depression. So in your treatment room, you might notice catastrophic language. They say things like, "I'm never going to get better," or "I'm broken." Not just once, but repeatedly. It's a pattern. They have hypervigilance about their pain. They're constantly checking their symptoms, fixating on every sensation, going, "Did that hurt? Is that worse than yesterday?" They experience avoidance behaviors, saying things like, "I can't do that, it'll hurt too much." And they're not just being cautious. They're avoiding things because of fear, not because of actual pain. There's also emotional dysregulation. They cry easily, they're irritable, or they're numb like nothing matters anymore. And they can even start experiencing sleep problems, appetite changes, or social withdrawal. They're isolating, they're not sleeping, their whole life is shrinking. Now, the research also identifies specific psychological risk factors that predict poor outcomes. These are the yellow flags that you should be watching for. Catastrophizing. This is where they're saying that this pain is unbearable and will never end. They have fear avoidance beliefs, saying like, "If I move wrong, I'll do permanent damage." They have low self-efficacy, saying things like, "I don't think I can handle this." They have negative treatment expectations, thinking that nothing ever works for me. There's perceived injustice, where they have thoughts like, "This shouldn't have happened to me, it's not fair." And they can even have anxiety and depression symptoms, like the stuff that we just talked about. Now, here's the good news. You don't need formal questionnaires to spot this, although they do help. You just need to ask the right questions. So, when you're working with a patient, try asking, "How confident are you that you'll recover?" And have them give you a number from 0 to 10. You can ask, "What worries you most about this injury? Has this changed how you see your future? Are you avoiding activities because you're afraid of making it worse?" And listen to their answers. Really listen. Because what they're telling you is whether their appraisal has shifted into crisis mode. And here's the key. We're not diagnosing anything. We're simply noticing when someone's distress level is high enough that it might be interfering with the recovery. And that's absolutely within your scope. Now, you might be thinking, okay, but why does this matter? Why should I care about their mental state if I'm just a massage therapist? Well, the research is pretty clear. Distress following musculoskeletal injury is associated with delayed recovery, higher disability levels, delayed return to work, and an increased risk of developing persistent pain. You're not just dealing with tissues, you're dealing with people whose thoughts and emotions are shaping their recovery. So, when your patient comes in with a shoulder injury and they're catastrophizing, avoiding movement, and convinced that they're broken, that's not just a mental health issue. That's a recovery issue. And that's your issue that you can help with. And that's why crisis intervention matters. The research shows that crisis care can reduce hospital readmissions and is more effective than standard care for improving mental state. So, by recognizing distress and intervening early, you're not overstepping, you're actually improving outcomes. Okay, so now let's address the elephant in the room. You've been told your whole career, don't talk about mental health. Refer out, stay in your lane. And I want to flip that for you with what the research actually says. First is the shortage problem. There's a massive barrier to delivering psychological care because of limited availability of mental health care providers, along with cost, geography, and disability. And here's the kicker. Patients presenting with physical injuries often resist psychiatric referrals because they feel their pain is being dismissed as all in their head. So when we refer them out, they don't go. They stay stuck. And second is actually the solution. It's transdisciplinary care. The literature suggests that delivering transdisciplinary care, where allied health providers like you incorporate psychological care into your practice, provides a significant opportunity to bypass these barriers and reach patients who lack access to psychologists. So you're not replacing a psychologist, but you are filling a gap. And third is the framework, psychologically informed practice. The primary framework for manual therapists intervening in mental health is called psychologically informed practice. So we'll just call it PIP for short. And here's what's beautiful about PIP. It's the middle ground between what you already do and formal therapy. PIP isn't therapy. It's recognizing when someone is struggling, asking the right questions, and helping them see their situation differently. You already do this with pain beliefs. Within PIP, you can integrate cognitive behavior therapy principles. You help patients challenge maladaptive thoughts, like moving my shoulder will tear it more, and then reframe them into balanced views. This reduces the fear and anxiety that lead to avoidance behaviors. And here's the research that should blow your mind. Systematic reviews have found that cognitive and behavior-based interventions delivered specifically by non-psychologists, like physical therapists and other rehab-focused clinicians, are effective in improving distress-related outcomes, including anxiety, depression, and fear avoidance. So you don't need to be a psychologist for this to work. In fact, sometimes it works better when it comes from someone like you, someone they trust, someone who's hands-on with them. And fourth is the power of your touch. And here's something else the research shows. Treatments provided by manual therapists improve distress outcomes not just through psychological exercises, but through the nature of the physical care itself. Physical interventions, including massage therapy, have been shown to have a positive effect on psychological outcomes like depression, pain, self-efficacy, and anxiety. Why? Because the mechanism behind these improvements lies heavily in the interaction between you and your patient. Your presence, your communication, your support. These foster reassurance and positive expectations. And this interaction can physically activate specific neurobiological pathways associated with stress reduction, improving their psychological state. So your hands aren't just treating tissue. They're activating their nervous system's ability to calm down. So the bottom line is, you're not overstepping. You're delivering standard of care. Now, I know what you're thinking, but what about my regulatory body? What about liability? What if I make things worse? Let me address these directly. Fear number one is always, I'm not qualified. And we've said it so many times throughout the podcast so far. You don't need to be a psychologist. Psychologically informed practice isn't therapy. It's recognizing when someone is struggling, asking the right questions, and helping them see their situation differently. You already do this with pain beliefs. This is just extending that skill. And of course, fear number two is the ever-strong worry that I'll overstep my scope. But the thing is, your scope includes recognizing psychological yellow flags and providing emotional support. That's not overstepping. That's being a good clinician. Referring out is still part of your toolkit, but it's not your only option. And fear number three, and maybe the biggest worry, is I'll get in trouble with my regulatory body. Well, the research shows that this is now standard of care. Transdisciplinary care is what's expected. You're actually better protected when you're informed and intentional about this rather than when you ignore it. And here's the thing. When you recognize distress early and intervene, you're preventing a crisis from getting worse. You're reducing the need for emergency interventions. You're improving outcomes. That's not risky. That's responsible. Okay, so here's what you do the next time a patient mentions that they're struggling or you notice those yellow flags. Step number one, listen and validate. Don't minimize. Don't rush to fix. Just say, that sounds really hard. I'm glad you told me. Step number two, ask clarifying questions. Things like, how long has this been going on? What worries you most about this? Has this changed how you see your future? Are you avoiding activities because you're afraid of making it worse? And then listen to their answers. Really listen. Step three, recognize the yellow flags. Are they catastrophizing? Do they have fear avoidance beliefs? Low self-efficacy? Negative treatment expectations? Perceived injustice? Anxiety or depression symptoms? If you're seeing multiple flags, that means their distress level's high. Step four, offer support. Saying something like, "I'm here for you during this. We're going to work through this together. Your recovery matters, and so does how you're feeling." Step 5, know when to refer. If someone is expressing suicidal ideation, severe self-harm thoughts, or acute crisis symptoms that are beyond your scope, refer them out. But have resources ready. Know who to call. But don't refer just because they're struggling. Refer because they need specialized care that you can't provide. And step 6, stay connected. You don't just disappear because you referred them out. You're still their massage therapist. You're still part of their support system. And that continuity matters. Now, if you want to go deeper on this, and I mean really deep, I did a full presentation on this in my monthly membership community. We covered screening tools to help you identify distress early, how to have some of those difficult conversations without it feeling awkward, and different ways you can intervene when necessary. Because the truth is, knowing what to do is one thing. Knowing how to do it, how to actually have that conversation, what to say, how to respond when a patient breaks down, that's another thing entirely. That's where the membership comes in. We walk through real scenarios, we practice the language, we address the objections that come up when you're actually in the room with a patient who's struggling. So if this resonates with you, if you're thinking, okay, I want to do this, but I need more support, that's exactly what the community is for. And here's what I learned as a firefighter. Being present in someone's crisis doesn't require a psychology degree. It requires presence. It requires listening. It requires caring enough to not look away. You're not a psychologist. You never will be. Well, maybe some of you will be one day. But you are a manual therapist with hands-on time, trust, and the ability to recognize when someone needs help. That makes you invaluable. The research proves it. Your regulatory body expects it, and your patients need it. So the next time someone comes to you with distress, with fear, with catastrophic thoughts about their injury, don't shut that conversation down. Don't hide behind, "I'm not qualified." Be present. Ask the right questions, help them shift their appraisal, and know when to bring in additional support. That's crisis intervention. That's standard of care. That's you being the ally your patients desperately need. Thanks for listening, and I'll see you next time.